Welcome to the Deep Dive. We take stacks of information, dig through them, and pull out those essential nuggets you really need. Today, we're tackling something absolutely vital. If you're in healthcare, studying for that med-surg exam, maybe you're just curious about how nurses make split-second critical decisions, we're focusing on patient safety, prioritization, delegation,
Right.
all viewed through real patient situations and key conditions like anemia and blood transfusions. Our goal today, to give you that shortcut, a practical guide, really, not just the what, but the how to apply it. So you feel ready, confident.
Yeah, and what's so interesting is how these different areas, chronic conditions, how you delegate tasks, understanding blood issues, that they aren't separate things. They all weave together. It's the fabric of safe, effective patient care. And we're going to connect those dots for you today, really showing the why behind these critical nursing choices.
Okay, let's dive right in with a patient scenario. It makes these concepts much clearer. Imagine Mr. Edwards. He's young, only 20. He's got a history of kidney infection and then a recent spinal cord injury from a car accident led to paraplegia, so paralysis in his lower body. Now, on top of that, he's dealing with a urinary stricture, a narrowing in the urethra, and he's on DVT precautions. We need to prevent blood clots. And he needs quite a bit of help with basic daily care. So for the nurse walking in, what does all this immediately signal?
Well, it immediately brings up chronic conditions and disability, doesn't it? Our sources define chronic conditions as these health problems needing long-term management, months, even years. Mr. Edwards is a perfect example of how these things hit any age, any background. It's not just the medical stuff, the paralysis, the stricture. It's the psychosocial impact, managing life day to day, the financial strain on his family, too. It's holistic.
And here's something that might surprise you, highlighted in our sources. Chronic conditions are actually the most common cause of death now in the U.S. It's not that we're getting sicker overall. It's more about, well, successes, really. Decreased deaths from infections, people living longer, much better screening.
Right. It shifts the focus.
Yeah, it fundamentally changes nursing priorities, more
Yeah.
towards long-term management education.
Exactly. And connecting that back to Mr. Edwards, preventing complications is just huge. Our sources talk about managing modifiable factors, things you can change, like smoking, diet, exercise, primary, secondary, tertiary prevention. For him, the nursing process is key. You identify his specific problems that DVT risk, needing help with ADLs, activities of daily living like bathing. Then you prioritize what's most urgent. Plan interventions like repositioning him every 2 hours, super important to prevent skin breakdown. And then you evaluate constantly, is this plan working?
The sources also really emphasize patient teaching. And it's not just giving a lecture, right?
No, absolutely not.
It's about understanding your patient, their learning style, their developmental level, even spiritual needs sometimes, and considering the family. For Mr. Edwards, his family is crucial. Teaching them how to help with his bathing, hygiene that empowers them, supports his care long term.
And speaking of support and safety, we have to talk about disabilities. Our sources bring up the WHO's framework, the ICF, and also the Americans with Disabilities Act. It's all about ensuring quality, equitable care. So you need to ask, does this patient need special accommodations, maybe communication aids? Is the facility accessible? Wheelchair ramps, interpreters? And critically, are we using people-first language, avoiding terms that, infantilize or talk down to people? It's about respect, dignity.
Okay, so Mr. Edwards' situation, it's complex, and it perfectly sets up the next big challenge nurses face. Juggling multiple patients, multiple critical tasks, how do you manage it all safely? That's where prioritization and delegation become essential tools. They're really the backbone of efficient, safe care on a busy unit.
Yeah. And our sources give us clear definitions. Prioritization, deciding what needs your immediate attention, what's most urgent right now. Delegation. That's when an RN transfers a specific task to someone competent, maybe an LPN or a UAP. But, and this is key, the RN keeps accountability for the task. An assignment is just, distributing the workload for the shift, who's responsible for which patients.
There's a great tool in our sources to simplify prioritizing the 4 Ps. It helps you think it through. First P, purpose. What's the patient outcome we want? Second, picture. What does the patient look like now? What do we expect after we intervene? Third, plan. What priorities match that purpose? And fourth, part. What role does each team member play? It's a really useful framework.
So how do you do that in the heat of the moment? How do you prioritize? The sources give criteria. First, is it life-threatening or potentially life-threatening? That's number 1. Second, would delaying this task endanger another patient? Third, is it essential for patient or staff safety? And fourth, is it crucial to the medical or nursing plan? These questions guide those rapid decisions.
And understanding priority levels is huge for patient safety and definitely for your exams. First level priorities, non-negotiable. Your ABCs, airway, breathing, circulation, foundational. Also, critically abnormal vital signs or lab values. Now, the big exception, remember this, CPR for cardiac arrest. Chest compressions come first, before airway.
That's a key distinction.
Huge. Then you have second-level priorities, things like sudden mental status changes, and watch out for UTIs causing confusion in older adults. It's common. Also, untreated urgent medical issues, acute pain, elimination problems, imminent risks like falls. Third-level priorities come next. Health education, rest, coping. Still important, but addressed after immediate safety and physiological needs. Think Maslow's hierarchy.
Okay, now delegation. This is about using your team effectively but carefully. The 5 rights of delegation are your safety net. You need the right circumstance, the right task, the right person, the right direction, and that communication piece is vital, and the right supervision and evaluation.
Get one wrong, and you risk patient safety.
And what's really, really critical is knowing what you cannot delegate. The sources are crystal clear. The nursing process itself, assessment, diagnosis, planning, evaluation, that requires RN judgment. You often hear the mnemonic TAPE. You can't delegate teaching, assessing, planning, or evaluating. Those are core RN responsibilities, period.
So who delegates to whom? RNs can delegate to other RNs, to LPNs, and to UAPs. LPNs, our sources say, are great for stable patients. Chronic conditions, predictable outcomes, they can do a lot.
But not new admissions or fresh post-ops. Those patients are too unstable.
Right. LPNs can give many meds, but usually not IV push meds or blood transfusions. UAPs are essential support. ADLs, ambulation, routine vitals on stable patients, invaluable help. Okay, practical scenario time. A nurse needs hourly vital signs on a patient getting a blood transfusion. Can a UAP do that? This comes up a lot.
Well, the sources emphasize that the RN is always responsible for the total care, regardless of delegation. So while a UAP can take vital signs generally, during a blood transfusion, especially those first 15 minutes, the RN needs to be hypervigilant for reactions. That's a critical assessment period.
So the RN should be doing it then?
Often, yes, especially initially. The review questions highlight this. It underscores the RN's accountability and need for close supervision, even for delegated tasks when the risk is high. Patient safety first, always.
Okay, let's shift gears a bit. Anemia. Super common, often needs complex care. Our sources break it down. Anemia basically means low hemoglobin, less oxygen getting delivered to the body's tissues, like running on low fuel.
So what should you look for? What are the signs? Our sources list fatigue, that's a big one, shortness of breath, maybe confusion, weakness, looking pale, a fast heart rate, and sometimes paresthesias, that tingling or numbness. And importantly, in older adults, anemia really bumps up their risk for falls and delirium, so safety is a major concern there.
Let's use another scenario from the sources. A 24-year-old African-American woman, history of gastric bypass surgery. She comes in, pulse is 110, respiration's 27, short of breath when she moves, pale mucous membranes. Based just on that, what type of anemia might the nurse suspect first?
That gastric bypass history is the big clue, isn't it?
Yeah, it jumps out.
Our sources point out that vitamin B12 deficiency is common after gastric surgery because absorption is messed up. The symptoms, the shortness of breath, pallor, tachycardia, fit general anemia. But that surgical history really points towards B12 deficiency as a likely cause.
The sources also cover iron deficiency anemia. That can cause specific things like a smooth, sore tongue, brittle nails. And a really key teaching point, iron supplements make stools very dark, almost black. You have to tell patients this.
Why is that so critical?
Because dark stools could hide blood in the stool, Melina, which might indicate a GI bleed. So patients need to know the dark color is expected from the iron.
And here's where you need to differentiate. Both B12 and folate deficiencies can cause fatigue and pallor, common ground. But only B12 deficiency usually causes those neurological symptoms, the paresthesias, problems with balance or proprioception. Folate deficiency typically doesn't. That's a key diagnostic clue.
Another critical one, sickle cell anemia, genetic disorder. Red blood cells become stiff, sickle-shaped when oxygen is low, leads to chronic anemia, jaundice, and these incredibly painful episodes called vaso-occlusive crises. The sickled cells block blood flow, causes tissue damage, intense pain.
So for a patient in sickle cell crisis, what's the priority? Our sources say immediate, strong pain medication, often morphine, plus comfort measures and lots of fluids. Hydration is key. It's a classic example of prioritizing in an acute situation. Pain relief and hydration are paramount.
Okay, now for a major intervention. Blood transfusions. This is high stakes. Patient safety, careful assessment, being ready to react fast, all critical. Our sources cover donor requirements, age, weight, health status, and different donation types, like donating for yourself, autologous donations.
And the testing. It's rigorous. HIV, hepatitis B, C, syphilis, CMV screening, plus meticulous ABO and Rh typing to ensure compatibility. But even with all that, reactions can happen, so you absolutely need to know what to look for and what to do.
Exactly. Knowing these reactions can save a life. Our sources break them down. First, febrile non-hemolytic, most common. Chills, fever. Using leukocyte reduction filters helps prevent it.
Okay.
Then acute hemolytic, this is the big one, life-threatening. Wrong blood type, often due to errors like mislabeling or wrong patient ID. Symptoms hit fast, fever, chills, classic low back pain, chest tightness, blood pressure plummets. Very serious.
Got it. Hemolytic, bad.
Very bad. Then you have allergic reactions. It can be mild hives or full-blown anaphylaxis.
Yeah.
Taco transfusion-associated circulatory overload, basically fluid overload, shortness of breath, crackles in the lungs, high BP. Slowing the infusion rate can prevent this, especially in patients at risk, like those with heart failure.
Makes sense. Too much fluid too fast.
Yep. Bacterial contamination. Risk is low, but serious. Can happen if blood isn't stored right or hangs too long, usually shouldn't infuse over 4 hours. And finally, Torelli transfusion-related acute lung injury, potentially fatal lung injury, causes severe shortness of breath, low oxygen within about 6 hours.
Okay, so if any reaction starts, what's the immediate nursing action? This is crucial. Our sources are unanimous. Stop the transfusion immediately. First step, always.
Don't even hesitate.
No. Then, maintain the IV line, but switch to normal saline. Run it slowly just to keep the vein open, KVO. Assess the patient right away, vitals, breathing, skin changes. Notify the provider immediately. And critically, send the blood bag and tubing back to the blood bank for analysis. Collect new blood and urine samples from the patient as ordered. That whole sequence is your rapid response, protecting the patient.
And one last point on safety for the sources. Sometimes there are pharmacologic alternatives. Growth factors, like epoetin alpha, Epogen, stimulates red blood cell production. Or filgrastim, Neupogen, boosts white cells. Sometimes these can help avoid transfusions. Wow, okay, we've covered a lot. From chronic illness and disability, right down to the nitty-gritty of prioritizing, delegating, handling anemia, and those critical transfusion reactions.
And remember, the real goal isn't just passing an exam, though this helps. It's about seeing how all these pieces fit together. Understanding these connections is what empowers you as a nurse to give truly safe, effective, and compassionate care. Every little decision matters. Delegating a task, noticing a subtle change, it all impacts patient safety.
So what does this mean for you, whether you're prepping for that exam or just fascinated by nursing? Next time you encounter a patient situation, think deeper. Ask, are there hidden chronic issues? How do I prioritize this patient's needs right now? What can I safely delegate? What absolutely needs my assessment? And how does everything I just learned about patient safety apply here in this moment? Keep asking those questions. Keep digging deeper. We really hope this deep dive gave you that shortcut, made you feel more informed and ready.